Good morning. Thank you for being here. My name is Eugenia Vasco, and I'm a medical student at the University of Catania. And today, me and my colleagues have the pleasure of interviewing Dr. Nicolas Caputo, who is Associate Chief of the Department of Emergency at the New York Health and Hospital Lincoln, and works also at the New York Presbyterian Hospital as an emergency physician. So as an introduction, we wanted to ask you, why did you become an emergency medicine doctor? And would you choose the same career path? And is there anything you would change?
Sure, absolutely. Thanks again for the invitation. Good morning, guys. And I would say I would absolutely choose emergency medicine again, 150%. It's probably one of the most diverse career paths one can take in medicine, and that's one of the reasons why I went into emergency medicine, is that we see the entire spectrum of medical pathology, and we're able to treat the entire spectrum of socioeconomic patients across the board, regardless of ability to pay. And the mantra in emergency medicine is basically anything, anytime, anywhere, and that's kind of what we do. Is we'll treat any patient for whatever malady they have, whenever they need it. And so I think, going into a shift, not knowing what you're going to expect, what you're going to see, is something that helps drive me every day to continue on in emergency medicine, because you can go in one shift and maybe you'll deliver a baby, and then you'll treat a gunshot victim, and then you'll treat a heart attack, and you'll go into another shift and maybe you'll just take a splinter out or have a conversation with somebody who's addicted to pain medication. So you truly do a little bit of everything in emergency medicine. That's what I really love about it.
Thank you for answering.
Hi, my name is Giorgio Maria Terminella, and I'd like to ask you if, looking back a year ago, the emergency medicine wards were not ready to face a global pandemic. But then, when it starts, how did you initially deal with the first cases? But today, how this working experience in emergency rooms has changed?
So yeah, last year, what had happened was pretty unprecedented. We haven't had a global pandemic in, I don't know, probably over 100 years. The Spanish flu of the early 1900s was the last true global pandemic. And so for us, in all honesty, we were unprepared. Last March, it was pretty much damage control and mass casualty. Usually in mass casualty scenarios, it's a brief period of the event. So you have an explosion go off, or there's a major motor vehicle accident and they bring in like 5 or 10 patients, mass cash, and it lasts an hour or so, and then you're kind of done. But this was protracted over months, and nobody really knew how to deal with that. So it was really a great learning experience in mass casualty, damage control, medical logistics, that we kind of sort of learned as we went along. We kind of made adjustments and course corrected as each day progressed, and we learned little lessons from each patient interaction. One of those things being proning, putting patients on their stomachs, doing that for awake, non-intubated patients. That was a quick lesson learned in order to stave off intubation. And today, I think what it has done for us, it has taught us all to keep an open mind, and how an open mind, critical thinking, things like that can really help improve patient, kind of our approach to patient care, and really, getting to think outside the box, how that's pretty critical in mass casualty, and not just mass casualty, but also in just medicine in general, is thinking outside the box. We're very reflexive in medicine, meaning like somebody comes in with a specific complaint and we have an algorithm that we automatically follow. Well, not every patient fits that algorithm. So sometimes you need to think outside the box and stray from that algorithm in order to figure out what's going on with the patient and best course of action to treat the patient. So I think those were the biggest lessons that we kind of learned from the pandemic.
Thank you.
Hi, my name is Luca Varsalona, and I was wondering, we know that physically and mentally the work of an emergency doctor is very stressful. As you said, every day you have to take the risk of finding something you have never met before in your career, which you have never read about in books. So, has this ever happened to you, and what was the most challenging trauma you have faced, and how did you behave?
Yeah, of course. I mean, this happens pretty frequently where you have a patient that comes in and you don't know the answer. That's going to happen more times than not, especially in emergency medicine. It's hard to say one case. I remember one really challenging case of a guy that got stabbed in the chest, and he was a homeless guy, and he came in, and to everybody he just appeared to be short of breath, and he kind of lost vitals right in front of us. So the patient came in, was really huffing and puffing, breathing really hard, couldn't really say what was going on. He was pretty intoxicated. And so the nurses put him in the resuscitation room. They brought me in. I, walked in and said, I'm Dr. Caputo, what's going on? And he really couldn't verbalize what had been going on. He was just breathing real heavily. I kind of thought it was like a COPD exacerbation or an asthma exacerbation. And then he kind of just died. He just coded on us. And that was like the oh shit moment, like, oh God, what's going on here? So we cut his clothes off and realized he had a little cut in his chest. And at that point, it was like, oh, somebody stabbed him. And he had so many layers of clothing on that we didn't actually see the blood. We didn't see the defect in his clothing. So when we took the clothes off and we started to see the blood and then saw the defect in his chest, it was like, oh, all right, I kind of know what's going on. He got stabbed in the chest. So we did a open thoracotomy, where you cut the chest open, delivered the heart, found the defect in the left ventricle of the heart. And basically we put a Foley catheter in there and up the balloon, and we started putting blood through the Foley catheter. And we stapled around that and did an internal cardiac massage. And the patient's heart started to fibrillate again, which was pretty cool. It's like, oh, wow, like we've got something going on, right? We shocked him into an organized rhythm, and then the trauma surgeon took him up to the OR, and he walked out of the hospital like a week later. So that was one of those scenarios where it was like we weren't really prepared for that situation. He came in, looking a certain way. We kind of thought, all right, maybe he's, respiratory, got some underlying pulmonary condition, and he ended up being stabbed in the chest. And you just have to think, on your toes and react quickly in those situations.
Of course. Thank you.
Hi, I'm Andrea Salvo, and I wanted to ask you two little questions. First of all, talking about the administration, do you think that in America everything is organized properly? And then also, if you could tell us the peak and the week of your ward.
So the first question in terms of organization, I always think things could be organized a little bit better. I mean, emergency medicine in general is sort of organized chaos, but in terms of the medical system, I think it's well enough for the purposes it serves our population. It's not perfect; it's far from perfect, but I think it functions well. And your second question was what?
If you could tell us the peak and the week of your ward, maybe which is the best aspects of it and the worst aspect of your workative ambient, maybe.
Yeah. That's a hard question. I mean, I really love work. I love emergency medicine. So, the weeks that are good are the ones where the volume is high, the cases are interesting, and things are working. The weeks that are worst are when the volume is high, the cases are interesting, but you don't have the supplies, you don't have the ancillary staff that you need to actually treat those patients. So, it's really comes down to what resources you have. at least for me, to have like a good, experience in the emergency department. The patients are great, the staff is great, but if you don't have the resources you need to treat the patients properly, then that can really dampen your day. Yeah.
Yes, I understand it. Thank you very much.
Okay, one last question. I'm Oliwia, and we want to thank you again for joining us. So the question is, when a patient comes to the hospital, what are the decisions that have to
triage system that classifies the patient from category 1 to 5. So there's ESI 1, 2, 3, 4, and 5. 1 is the worst, basically means you're in cardiac or traumatic arrest. 5 is the best, basically meaning you just need to speak to the doctor for whatever reason. So the way the system works is the first question that is asked when a patient presents to the emergency department is, does this patient require immediate life-saving intervention? So somebody who's in cardiac arrest or traumatic arrest or, very limited other sort of presenting scenarios, right? And if the answer to that question is yes, the triage nurse then labels the patient as an ESI 1 and they get full resources of the department. So they get everybody that needs to be evaluating the patient immediately. If the answer to that question is no, then the next question is this patient at risk of decompensation within the next, 30 minutes or an hour? Okay. And those patients are going to be somebody that's having like crushing chest pain or difficulty breathing, things like that. And if the answer to that is yes, then that patient needs to be seen within 30 minutes of arrival. The answer to that question is no, then it goes from a less subjective kind of system to a more objective resource-based kind of system. So the next question is, how many resources does this patient need? Do they need no resources, 1 resources, or more than 1 resource, right? If they need more than 1 resource, and a resource being like a person who comes in with, just abdominal pain, right? Non-specific, had diarrhea, they don't need immediate life-saving intervention. They're not at risk of decompensation. So it's all right, what is this patient likely going to need in order to figure out what's going on? Well, a lab is a resource, an EKG is a resource, an X-ray is a resource. So if this patient needs labs and an ultrasound, then that's 2 resources. So then they get labeled an ESI 3, and they need to be seen within 2 hours of presentation. If they need 1 resource, so say they only need like blood work, right? Then they get labeled as an ESI 4, and then they need to be seen within 4 hours. And if they don't need any resources, they just need a prescription refilled because their abdominal pain is gastritis and they need Nexium, then they get a label as an ESI 5, and they can be seen kind of whenever we get to them. Okay. And then the way it works is once they get that ESI designation in our emergency department, they go to a specific area of the emergency department. So all of our ESI 1s and 2s, the most critical patients, go to the critical care area of the emergency department. Our 3s, which are our our urgent patients, will go to a specific area of the ER that is staffed with much more doctors and nurses, because that's where the highest volume of patients go. And then the 4s and 5s go to the fast track because they need little resources and little things for them. So we kind of speed them through the process. And that's sort of how we dictate flow and patient care when a patient hits the door in the emergency department.
Okay. That was the last question. So it's all. And thank you.
No problem.
Thank you for your time. Thank you. I hope you enjoyed the interview. It's been a pleasure for us. So thank you.
Thank you, guys.
It was really interesting. Thank you.
Well, thank you, and reach out anytime, guys. All right.
Yeah.
Okay.
All right. Thank you. Bye.
Thank you.
Okay, bye.
Bye.